The idea here is to stimulate discussion among people, so questions, and also if you have vantage points, welcome them from you. Who wants to kick it off?
One issue you didn't seem to address is the fact that medical records have different degrees of security. You can always think of layered security. For instance, if I go to my dentist, I don't want to know anything about anything other than to do with my teeth. If I visit some other kind of health professional, I may want them to know that I've had a mental problem or have HIV or something of that nature. Any comments on that kind of thing?
The issue of a doctor having full access to all your medically relevant information is something that comes up a lot when talking with doctors. That a doctor will typically say, to treat you properly, we need to have access to everything because you never know what could have implications for your treatment. Be it, if you don't tell the doctor that you're taking this medicine and they prescribe something else and there's a conflict and they don't know, if you have had some sort of trauma or what have you. It's clearly an issue. It's an issue that we discussed, the concept of a medical lockbox, where some information could be basically removed from your file and not transmitted to other doctors. This gets back to the whole concept of consent. And it's tricky for people to say, no, I don't want this doctor to know the fact that I was treated for mental illness, when all they're dealing with is treating a broken leg. Clearly, it may not be medically necessary. The ability to control that access, the consent treatment. If I go in and I go in for a specific medical treatment, it shouldn't be that difficult for a doctor to say, this issue is complicated, I may need to discuss it with some of my colleagues. You consent to that. He shares medically relevant information with the colleagues for that purpose. That's consistent purpose. For everyone to have access to all your medical file, clearly that's unnecessary. Doing that in practice, on a technological basis, is going to be tricky. If people have access, and that's why we say that it's important to design these systems from the beginning. There's lots of systems out that have that different hospitals are working with. Some have got, say, a doctor, rather than having paper charts, a doctor would walk in with a little Palm Pilot. He comes within 10 feet of the patient. The information is zapped to his Palm Pilot. He sees it. He can go, okay, I need 10 milligrams of something, tap, 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 so the system can actually read his writing. He can sign it, check it off, move 10 feet away, screen blanks, data dump. There's no charts lying around. You can have the same thing with log-on systems, proximity cards. I log on to the system. The worst cases of abuse are not malicious. There's someone's charts lying around. Someone logged onto the network. I come up and I've got a legitimate use for the network, and there's Mr. Jones in C12, and there's his file. I have to get out of that. So design your system so that the person literally walks away, the screen logs you off, the next person has to log on and get it to that. We can design systems that are much more privacy protective, and they're not particularly complicated, but you have to go in with that frame of mind.
I was wondering about gatekeepers for that. Your example that you gave about the individual not wanting someone to know he or she had mental illness because it was a broken leg. I could argue and say, well, for mental illness, maybe they were on an antidepressant, which might affect something that was given for the pain in the broken leg. So a gatekeeper like a family physician, could not people give permission to that person perhaps to share health information as required from a specialist or another country or something?
Well, again, the whole concept of consenting to the release of information. The doctors have a particular view. Patients' advocacy groups have a specific view. The Consent and Capacity Board will have a specific view. it's not easy, and that's why we want clear guidelines in the legislation. And one of the things that I didn't say earlier was that when our office takes sort of charge of this, which we're assuming we're going to have, there will be an assistant commissioner for health information. That our plan is that that person will have a medical background. A lot of these issues are, regardless of what's in legislation, the practicalities of them, the implementation of them, the regulations that will go along with the drafting of the legislation. There's still a lot of issues to work out. Consent is, on one level, it's very simple. You can have the information, you can't have it. But as you say, a doctor will typically want to know the whole things. A lot of doctors, when I go to my dentist, they check my lymph nodes in my tongue because a lot of illnesses show up in the mouth ulcers, what have you. I think that my doctor is caring and concerned about my health when they're doing that. But equally, if they're saying, I think these are early symptoms of what have you, and they're incorrect, and that somehow goes off to an insurance company, what are the potential implications of that? So the issues are very sensitive and they're very complex, and I don't know how we're going to solve them all, but somehow we've got to here, and the world hasn't ended, so.
Ron, repeat the question.
From what you said early on, I take it that your interpretation is the patient owns his medical information.
Yes. The patient's record, the patient's file is their file.
Owns his information. And does he have the right of determination of the use of that information?
The patient should.
Just that, in that very narrowly defined thing. He has the right to grant consent or to withhold consent.
That's the basis of our view and the basis of the legislation.
Is that principle, do you know, accepted, generally speaking, by the medical profession and by politicians and the legislature?
Well,
that matter, that simple principle, that the patient, not the medical system, owns that information, is pretty important.
I think that the draft legislation starts off quite specifically by saying there's a large section on consent. Sorry.
While you're looking that up, I'd like to make a comment on that. Is many physicians, if not the highest percentage, believe they do have ownership of information in the chart, and not necessarily all of the information. And secondly, they have intellectual property rights to it. So that, for example, if they make a note in that chart that has potential commercial value, that is owned by them, not by the patient. So the issue is which parts of the information perhaps are owned by whom. And that is an open question as of now, as far as I understand it.
Yeah, I don't think that we would debate that a doctor's diagnosis or interpretive comments are the patient's.
It might seem facetious to say it, but you're quite right in that that's what I understand a lot of doctors feel, and a lot of participants in the healthcare system happen to feel. That's why I was interested that the comment made that the patient owns the system. It's been my feeling that the doctor or the hospital may very well own the piece of paper it's written on, but the actual data is controlled by the patient.
Again, there are two kinds of data. That's what Greg was just, I think, going to touch on. Patient data and physician data, and there's where a divergence occurs. Do you have anything on that, Greg?
Well, the draft legislation says, and again, if this act requires the consent of an individual to the collection, use, or disclosure of personal information, the consent may be express or implied, except that the following consents have to be explicit. A consent to the collection of personal health information by an organization that is not a health information custodian. Therefore, Zellers, they're not a personal health information custodian. A consent to the collection, use, or disclosure of genetic information, dental floss. And consent that this act provides must be express and not implied. So, and it goes on for pages and pages of consent. Consent is the fundamental underpinning.
Principle of consent by the patient. The patient can consent to do various things, no matter how obscure the purpose might happen to be.
Well, there's also a lot of reasons why consent is not required or consent could be implied. It'll be up to a lot of health lawyers and health policy experts to determine how it plays out in reality.
Who owns the diagnosis? I go to a doctor, I have a medical record, I lay the medical record in front of them, the doctor makes a diagnosis of some ailment or other. Who owns that? The doctor or the patient?
Who owns the diagnosis? I'm not going to hazard to say.
I think
I had that feeling. I just wanted to find out.
Not just about diagnosis, but about ideas, thoughts, reflections, whatever they might be. And those notes may be a separate ownership from the ownership of the patient's information. So that's where the divergence occurs. It's really that. I do not know what the new legislation says about that. I don't know if you can.
Because if the doctor owns the diagnosis, then they can release that information independent of me.
Is there a lawyer from Philadelphia in the house?
I'm in Philadelphia, but I'm a lawyer.
He argues like one sometimes.
A doctor could release a diagnosis so long as it does not personally identify me.
Okay, good point.
So the distinction between my diagnosis, and I want to make sure I don't miss people on the side. Go ahead.
Just wondering if this new legislation is broad in scope or quite specific. For example, in the telemedicine field, if different projects are being set up all over Ontario to provide telehealth to remote communities, say, will there be, say, forms or specific legislation that pertains to telemedicine, or will it just really be a regurgitation of the CSA?
Whether this is broad or specific in scope, legislation by and large is supposed to be technology neutral and is supposed to be encompassing. So should this come into being, there will obviously be some regulation, because in legislation you can never get everything right, and especially as technology changes you can't be too prescriptive of what you say in the law. Regulations allow you a little more flexibility, but it should cover any use of personal health information, regardless of the medium and regardless of the purpose. So you wouldn't need specific for telemedicine versus anything else.
Supposing that I am the owner of that information, is there anything being built into a system that will allow me to go in and see exactly where my information has gone? Some kind of audit trail or anything like that when I want to know?
You have the right to access the medical information that is held by an institution. And
what I want to know is if my physician does have my record or my insurance company has information, is there any way for me to go and know that that's the only place it is, that it has not gone someplace else?
a properly configured information management system, be it paper-based or technology-based, should account for how information is collected, used, and disclosed. So a proper audit trail should say, much like the hospital example I gave you earlier, said, we know that your file was accessed by this person at this time. So they should be able to provide you a list. Whether every institution is going to have a perfect system that says who has accessed it, that's why...
Closing the barn door after the horse is about 3 miles away.
Now, there is a real issue here in the HIPPA legislation in the United States. It's my understanding that that issue is addressed, that the person or organization to whom the information is disclosed must be provided explicitly. The systems must record that. And also, places the information goes must be able to be there. So the legislation addresses that. The Ontario proposed legislation, does it address that directly? Are you aware? Or?
I'm not aware. It may, but...
There's one thing to say, a system should be able to do it. If it is not legislated, our systems will not do it. And I would say, well, we've got our expert in one type of system in the back. I don't believe you record at this point in your system who accesses all information, or do you?
We do. I think we've released actually information that's released to an insurance company is tracked, and you would give consent if you've given your consent to have your information released, and that's you can track that. And I believe that there are group entry systems available to track all accesses. I think one thing to think about is it might create a bigger system to track who's had access to information, because you want to have every healthcare professional who provides you with any care that needs access.
So right now, if Nurse Cratchit accesses your record and Dr. X, and you record that in your system, there are issues of capacity even dealing with that.
Yeah, I guess, the reason I'm asking this is I'm not so afraid of the hospitals. I'm more afraid of the private sector. And so, again, if there's a standard put in place by legislation that, everybody's got to come up to, maybe it's a false feeling of feeling safe, but at least with HIPPA, I know that there is something there, whereas I agree with you. If it's left voluntary, it costs money to do it, and I really don't believe it'll be done unless that standard is put in place, almost like licensed.
I think before you feel real secure about HIPAA, you should recognize that that part of the regulation was pulled out in the second round. The audit is no longer required by the system.
Is that right?
Really?
The full disclosure audit isn't. However, consent is the real issue here. If you have a system of rigorous consent, then you know where your information went, because it only went there because you consented for it to go. All the audit trails in the world will not tell you that your information was improperly or illegally disclosed, because they're not going to put that in the audit trail. They never will.
This is what I wanted to ask you we were talking about. I'm given to understand that if you make an application to an insurance company anytime, anywhere, for some kind of protection, whether they accept it or turn it down, that application goes into a sort of a general catch basin, and that all insurance companies sort of throw their thing in, so they can...
That's the MIB.
Well, yeah.
Information.
Now, if the new legislation comes out, can you go into that and say, and get rid of all that personal information if you choose to?
That's private based on, is that covered, is the MIB or equivalent to that may exist, that's in the States, I believe. Is that covered in Canada? If your insurance information is put into a database in the private sector, does the legislation address the private sector storage?
Yeah, legislation will cover any health information custodian.
Interesting. So now, if it goes to the States, that might be a different issue. It might be that resides down somewhere in the northeastern United States, I understand it, but that may be an escape mechanism there.
I want to go to the real estate business in Buffalo, because there can be a whole lot of databases down there that will
That's what will happen.
Yeah.
I mean, if you can migrate it across the border and avoid regulation, certainly a possibility. Watch the time. Everybody make comments from over here. Anybody want to make a comment or ask a question? I want to put a different issue on the table. We had two think tanks recently, and one of them was on security, and a person came from the federal government who was talking about the privacy legislation in Ontario. And when our psychiatrist, who's not there for our treatment but part of our team, heard the legislation, he said physicians won't accept that there is a degree of invasion of the physician's role and the ability to execute his or her responsibilities with respect to the patient in the current legislation. If you had comments on this, and has it been consulted out to physicians who have looked at the legislation in detail?
Well, I think from the doctor's perspective on the draft legislation, the best thing would be to review the Ontario Medical Association submission. One of the things that clearly they have raised is the whole issue of consent and how they can do what they need to do to treat the patient. Whether a patient, one of the fundamental concepts is also the concept of informed consent, that you just don't sign a form. And, I mean, we all sympathize when someone is, the example is, someone goes into hospital, they're, in a car crash. They can't very well consent to treatment. The idea is you have presented yourself in such a form and fashion that the system will get you capable of being aware, and either you or an agent can then subsequently consent to further appropriate treatment. They can't very well say, well, we're waiting for them to come around again or staunch their bleeding so they could scribble a form. So I think we're going to have to work with practicalities of the system. But the underlying basis is it's supposed to be based on informed consent, that people know what they are consenting to.
But why wouldn't the principle of the living will apply? If you can designate what your treatment will be when you're in extremis, why should you not be able to sign a form that would govern the use of medical information in an emergency?
A living will is probably a great example, but if someone has a car crash in the 401, again, the practicalities of finding out who, if they have a living will, who has it, how do they get access to it, how do they legally...
Donor card. I sign an organ donor card. If I'm killed, you can go harvest. Why can't I sign a card that says, if I get in an accident and I'm wheeled into an emergency ward unconscious, then you can access whatever medical records you can find in order that I have the best treatment I can expect.
Well, that's going to be on your smart cards. They could also make sure you got your OHIP number and you get paid for it.
Somebody proves to me how the hell you're supposed to update a smart card.
Other comments or questions? I'm surprised that the people involved in the technology, I have a great concern with regard to many of our institutions operate on quite old legacy systems. And they don't have the technology, fundamental technology, to do potentially some of the things that are necessary here. Could there be legislation where there isn't the effective mechanism to implement the legislation in our systems today? How do you deal with that?
Well, I think the legislation is supposed to be technology neutral. So regardless of whether it's a paper-based system or a network-based system, the technology, the whole concepts underlying consent, collection, use, and disclosure should be immaterial. I mean, if it's no different if someone emails 900 patient files to someone inappropriately or walks 900 patient files across the road. The technology is a means it's a facilitative means.
Maybe specialize the question. We have an existing computer system in Hospital A, which doesn't give you the tool set to meet the requirements of the Act. So in other words, technology is less than the requirements of the Act.
Many organizations in the States have been grappling with designing HIPAA-compliant software systems. It is a challenge. It is expensive. It's not to say that there's not going to be the necessity to retool.
Well, let me take that because I think this is an interesting point. In Ontario, we heard from John Oliver earlier in the series that Ontario hospitals spend on average 1.6% of their operating budget on IT. In the States, the average is 2.6%. In academic medical centers, it's closer to 5%. So you're just going to tell people who don't have adequate systems because feel they can spend too little money to retool in an economy which is effectively input control. It sounds like a conflict between the legislation and the requirements of the Act. I don't know if other people react the same way. It sounds like we've got an issue here that needs to be. Now, I'm pleased that there would be something like HIPAA that would literally force us to renovate our systems. But I don't know where that money is going to come from in our controlled economy. Sorry, go ahead, Carmen.
Well, I would just say that I think if the legislation is going to be technology neutral, I don't think it's really addressing the issues out in the field. Say for instance, you have a doctor and a patient in the same room. Doctor explains something, the patient consents. Okay, fine, it's simple. When you have a doctor behind a video screen and a patient 1,000 kilometers away, I mean, all sorts of issues like should the door be open, informed consent. There's all sorts of little legal issues that need to be addressed in technological situations that aren't in the general hospital normal setting. So I think if the legislation doesn't touch on that, I think it's too bad.
So for example, is someone else in the room with the doctor where you cannot see who that is? That's a very important one.
But that would be an inappropriate disclosure. So it doesn't matter whether I inappropriately disclosed by giving someone a piece of paper or inappropriately disclose your information by having someone sit in the room without telling me. The concept is the same thing. You have inappropriately either collected, used, or disclosed my information.
But I think with this new technology, it's easy to go around those issues. I think if it's a personal relationship, it's easy for the patient, for example, to see who else is in the room. In a video situation, it's not. And if there aren't specific guidelines that guide the doctor as to exactly what...
But that's not really the role for legislation. That's the role for perhaps regulation, perhaps guides of good practice, perhaps for the OMA or the CMA to design technology groups to design, if you are going to do this sort of process, be it telemedicine or electronic prescription renewals. These are the basic underlying technologies, the security implications. These are what you're going to face. There's no way legislation can address things to that degree of detail. I mean, as it is now, this thing's 126 pages long. If we put in every specific example of if you're doing this and this is how you do it, you wouldn't be able to lift it off the ground. It'd be like the U.S. tax code.
The actual literal output of the HIPPA legislative process was 32,000 pages in length. There's nobody who reads that and understands it. Everybody reads the part that they think they understand, or the section that they think is important, and then they assume the rest of it's okay. I mean, it was an impossible, and that's exactly why the whole issue about audit trail fell out of this, because it couldn't be technology neutral. How do you keep an audit trail when a medical record sits in a card on a local nursing home? You'd have to camp somebody by the damn card to watch who came in and sign it in and out to them every time. There's no hospital that can afford to.
So your argument is that the legislation should be technology, it has to be.
It has to be technology neutral, and it has to be relatively high level. The enabling regulations have to be more and more specific as they cascade down. But you can't write it in the legislation charged with it because it really fail.
Good point.
Question about compliance. Under existing Hawaiian privacy law, the Commissioner's powers are relatively weak with respect to privacy compared to access to information. What powers would the Commissioner have under the new legislation to make sure that all the stupid gaps that happen out there in the real world are rectified?
Investigating stupid gaffes and rectifying stupid gaffes are kind of different things. In our consultation paper, we did specifically talk about the enforcement, the powers of the Commissioner. One of the things that we are concerned with was much like in the Province of Ontario Savings Office issue that we had. We don't have in our current legislation and in the proposed legislation the power to compel witnesses to testify. That's a big deal. If people don't have to tell you what is going on, then it makes your ability to do an investigation extremely difficult. I believe the government's view is that, well, you have order-making authority, and so you can just, if they don't tell you, well, you can just figure out whatever you can, and you can just order them to do something. Well, that's really not getting at the whole thing. If you really want an effective oversight mechanism, the power to compel witnesses and to compel testimony, which the federal commissioner has, is fundamental. So there are a few issues in specific. The other issue is the power to compel production of records. We want clear oversight, investigatory powers for the public to know that if there is an issue, then we can appropriately deal with it rather than using moral suasion and implied powers, and hopefully that they feel that the bad press is worse than any potential issue that could come out. It would be nice if we could, I mean, there are cases all the time that we would prefer if we had the authority to just go in and seize records if they're inappropriately stored.
I'll just give you a quick example. I had some oral surgery about 3 years ago, and so I was referred to a surgeon who I'd never seen before. Of course, they ask you a lot of questions when you see a health professional for the first time. Now, it was a fairly small office, and so the receptionist asked you the questions at the counter in the waiting room. One of the questions was, are you HIV positive? Now, I understand why they're asking you that question, I didn't like the way that they did it, but of course I wasn't HIV positive, so I wasn't concerned. But that's obviously an inappropriate practice. Now, if I complain to the commission or the oversight body, who is going to force that oral surgeon to reconfigure their office to make sure that that doesn't happen?
I think what we've tried to do is to work with organizations. We've in the past not had a punitive mentality. We, much like the ministries that oversee elevators and amusement rides, if you violate the law, they fine you and tell you to fix it. We would rather work with organizations and help them design their practices to avoid potential problems rather than just punishing them and tell them to make it better. Because if one organization is doing it wrong, potentially others are, and we want to help develop a series of best practices. The medical case is perfectly legitimate. I know one of my colleagues, her mother was in awaiting surgery, and the doctor, she's in a ward, and the doctor pulls the drape over and then proceeds to tell, well, this is what we're going to do, and I can't, it's not going to be easy, but I think if people go in with a sensibility and a degree of sensitivity to these issues, then hopefully we can get to it.
Final comment in the back there, and then we'll call it.
One of the things we've been doing in clinics for some years about your question for privacy is to have people put in their own information in the computer. We've created quite inexpensively areas where people can plug in. Only then will they tell you about HIV positive. They always lie. They will never tell you about that. Who would? Verbally. But it hasn't been too expensive. It was only a very minimal start, I think, and this is some years ago.
Mm-hmm.
So hopefully from there we'll be able to do
And I think as organizations become more aware of issues, then best practices will come out. Will they address every single potential office, clinic, healthcare custodian? No, but the idea is that you learn from the best practices. The Canadian Blood Service has had to change its practices regarding information collection, and it's got a very rigorous. I think it's probably off-putting for many people. The 29 questions of have you ever eaten pork in a deli in New Brunswick. But it's necessary to ensure a system. So.
Is this at Mount Sinai Hospital? I want to thank you very much and thank everybody for the discussion. Turn it back over to Shirley.
Well, I found this quite a very interesting talk. Thank you, Greg, for coming and visiting with us. And can we all show a round of hand of appreciation?